Very interesting area. We take those things for granted. We have to listen to what was just said. Eat right, take care of your bodies, it makes a difference. All right. Our next presenter he has received awards of outstanding contribution in the field of substance abuse education by the National Council of Drug Abuse in 2007 and UWI Faculty Medical Science Award for Best Psychiatric Research Poster in 2007 also. Yeah, this is his own, it's long. Recipient of Principal's Award for the most outstanding research activity in the Faculty of Medicine. A recipient of the Award of Outstanding Contribution in the field of substance abuse. Going back to the next page. President of the Jamaica Psychiatric Association, a member of the Behavioral Modification Committee, Ministry of Health of Jamaica. Dr. Jeffrey Walcott was born in Clarendon, Jamaica, attended Clarendon College. You see, we have to go to the high school and the primary school, you know. I tell you, where are the Clarendonians? Yeah? Okay. You're in good standing, bossy. Dr. Walcott was the recipient of the B.O. Fraser Reed Award for Chemistry and was head boy of Clarendon College. No, man, yeah, sit down, man. When you send along something, come give me fun. No, man, no, have a seat. So finish, man. 30 seconds and we're ready for you. You know, want to hear the good stuff. He has conducted research in prevalence personality disorder in a general hospital in Jamaica and has the following publications, such as the psychological correlates of dependency in the Jamaicans population, correlates of psychosexual issues in Jamaican population, personality disorder in Jamaican murderers. He's the father of 4, 2 girls, 2 boys, and the resident committee chairman of Alpha Boys Home, Kingston, Jamaica. Everyone, welcome Dr. Walcott. See the good stuff.
Right, so it's always a pleasure to speak with my colleagues about mental disorders and the psychiatric aspects of life. All right. But this was a very challenging uphill battle when it comes to putting this presentation together. Because I had to ask myself, what is stress and why is it that we keep getting all hung up about it? And what are the mental disorders that are really caused by it? And then I went through the list and it was all of them. Yeah. And then they said 30 minutes. So yeah, that's a bit stressful. So the issue is that life is really stressful, but not quite. And psychiatry has always gone in circles. We're like that. Hence you see why most of my work has been in the field of drugs. We go in circles a lot and we like drugs. The reality is, we spend a lot of time trying to prove to people that psychiatric disorders are real. But then we have also the understanding that a lot of the problems that you have in life are made up. So it's complicated, yeah? But this is in fact true, and this was a quote that says that only 10% of your outcomes in life are due to actual events and experiences. 90% are made up in your head. And then you cause things to happen. So I guess you make up things and then you make them reality. And that is in essence what happens in people with stress. It's made up, but then, yeah, you make it happen. So your brain is a powerful thing, yeah? So the construct is, what is stress? What is stress, yeah? So we've had our dear colleagues from medicine give you the medical definition. And as a psychiatrist, I think it's only fitting for me to give you a physics definition because they both start with P. So stress is force over unit area. And that's exactly what it is. Yeah? That's exactly what it is. Physics is fantastic. That's an actual physics graph that shows you what happens. It's force over unit area, which is what it is. And psychology, psychiatry is no different. It's force applied to unit area, which is your brain. Now, two things happen when you apply force over a particular area. You have increase in tensile strength, which means that you have to internally get stronger to deal with it, or you move. Yeah, you move. Because if you apply enough force, the object you expect it to move. And that's what life expects you to do. Get stronger or move. But some of you stubborn. And then that's what happens. Because some of you refuse to get stronger, and you also refuse to move. And then that's when I come in. Did I mention we love drugs, huh? So that's when we come in. Because what happens after that is that if you don't get stronger or move, you start getting twisted out of shape. And this is in essence what happens in the psychiatry of stress. So let's give you an example of some of the stubborn ones of you. So what are you looking at? What do you see? All right. Hands up all the people who see the vase or the vase. Yay, a lot of you. Hands up all the people who see the two faces. Yay, a lot of you. Who see the two faces first? Yay. So we've identified the stubborn people. Right? It's true. It's all right. It's okay. Listen, it's fine. There's drugs for that. But the two faces are not real. And that's why I keep telling you, you're making things up. Okay? Okay? This is a picture. This is a picture of a very beautiful vase. The rest of it doesn't exist. But the faces are what we call negative images. And like everybody else, when they're dealing with stress, they think that by getting their brains to focus on the negative, it's something extraordinary. It's not. It's stubborn. Negative doesn't exist, but negative affects you. So part of the problem in terms of when you don't deal with stress well and when you start having the problems is because you're focusing on the negative aspects. So the negative thoughts, which are toxic, and they start to make you sick, they affect how you view outcomes, how you view your own actions and behavior, and then your own behavioral pattern becomes self-perpetuating of a mental disorder. So you're making yourself crazy, more or less. And it causes a lot of problems, right? So this is the issue with negative issues. And this is one of the most classic negative illness that you have. Fear. Because also, fear is very made up. Think about it. Any circumstances that you can name that you are fearful of, you are afraid of something that's not real. So if a guy comes up to you and holds you up with a gun and you start to get afraid, you can't fear the gun can't hurt you. It's the bullets. By the time the bullets have hit you, you don't have no more fear. So it was pointless to begin with, right? It's true. It's true. Every situation that requires fear, it's you focusing on something that's not real. Yeah? So climbing to a tall, tall building, the heights will not kill you either. It's usually the landing. Usually. And again, if you've landed, there's not much to fear. So the issue about stress is really not about stress. It's about all the disorders that have to do with fear. and overcoming fear. And that's, in a nutshell, what most of the mental disorders that have to do with stress are about. See, everybody thought that depression was a stress-related disorder. It's really not, though, because depression has nothing to do with stress. Depression has to do with emotional dysregulation. We confuse the two, which is why we keep thinking that if people get depressed, if you fix their lives, they're going to get happy again. Yeah, that doesn't work. They need drugs, as do most people. So, let's understand what happens. And we've been through this already, because I know my two colleagues, I came prepared. So instead of going through things, I just brought pretty pictures so you can look and go, ooh, ah. So that's your brain, preferably off drugs. But that's your brain and your nervous system. Now, as we said before, the issue of stress and the correlation of stress, the disorders, all of them, affect your brain's interpretation of its events. It's really about your nervous system causing this problem. And your nervous system is very simple, right? Very basic. Gathers information through all your sensory modalities, your 6 sensory modalities. I won't ask you to name them, and no, ESP is not one. And it takes it to your spinal cord in the form of electrical impulses, and then it sends it all the way up to your brain. Your brain then identifies, interprets, analyze, contextualize, organize, planize. Planize is not a word. And then executes a response. And that's basically how your brain deals with everything. Let's take vision, for instance. Light images captured by your eyes, goes into an electrical impulse, and then goes to the back of your brain, right? And everybody understand that this is what happens in all of us, isn't it? Yeah? We agree? And we all see the same things, right? Yeah, you got me. Yeah, because you're all a little crazy. So what color is the dress? All the people who see blue, black, put up your hand. There's not a lot of you in here. Gold and white. Any other color but blue, black, and gold and white? Purple, brown. You need medication. Yeah, you do. Seriously, you know, drugs are necessary. So the issue is that all the information that goes to your brain is not all the same. So you can't think about it, how you interpret a particular event or a particular entity and then generalize it to everybody else. So you can't understand what someone else is interpreting when they're seeing the same things. But your brain has a little trick to it. It tries to do that. So it's a little crazy. Yeah? Your brain tries to do that. The reason why we can't do it, though, is because your brain is very inefficient. Not all the information that it gathers in the sensory modalities goes to it. It screens a lot of it out and it only focuses on what it deems to be an immediate threat. So your brain is already set up to potentiate all the problems that have to do with stress. Because it says, oh, I'm only going to focus on what's going to kill me. And then everything it focuses on then becomes something that's going to kill you. So when you sit down and start focusing on your exams, oh, it's going to kill me. Everything starts killing you. And that's the basic underlying pathology that emanates from your brain's maladjustment to dealing with stresses and stresses of life. Because it always uses the same pathway. So, once your brain gets all information, limited that it is, it fills in the gap because it then starts to associate things that you did in your youth, in your childhood, blah, 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 things you've heard, and it starts to make up these beautiful stories. Yeah? Most of it is not real. And it's based on what your own perceptions are of your life. And so all the negative things start to flow into your brain. And it goes into these beautiful little circuits, called the Papez circuits, which go all over the brain. So the Papez circuits go through all your limbic structures, your cortex, back to your limbic structures. And what they are able to do is they regulate your perceptions, your processing, and most importantly, your behavior. Now, your behavior takes two forms. It's either motoric, which includes the mouth, yeah, which is mainly how you respond these days, or visceral. And the visceral response is mainly regulated through your autonomic nervous system. So in a nutshell, really, dealing with stress is all about dealing with disorders of your autonomic nervous system. And that's basically in general what it is, especially the neurological disorders, because all the disorders of stress really have to do with your autonomic nervous system and dealing with fear. And in your brain, there's a particular little thing that deals with fear, and that's called the amygdala. And the amygdala gives you this famous thing called the fight or... And there's a reason why there's fight or flight, because you recognize that not all of you do the same things when faced with danger. Some of you fight, others of you live to fight another day. I'm not ascribing a judgment call here, but yeah, some of it is ridiculous. So it depends on how your system is already set up. And that also helps to understand how you deal with stress, because I told you that once stress happens, you either get stronger or move. Yeah? Move. So it causes a cascading, and it also affects the neurotransmission in your brain. Mainly, guess which one? Norepinephrine, which we know is adrenaline, which is associated with your, come on people, it's basic fight or flight response. Yeah. And because it is associated with fight or flight response, all the problems that it's causing has to do with your fight or flight response. So your brain, which is normally beautifully cushioned in a dynamic, stabilizing force, gets thrown out of whack. You become hyper alert, you become agitated, and I put there all the states that are possible in your brain, all the things that affect them, the neurotransmitters, but most importantly, all the drugs that can correct it. We love drugs. So, the issue is that all that happens when you're under stress and you get the psychological disturbances is that your balance, your homeostatic balance of your brain shifts to a state of hyperarousal and anxiety. And those are the main disorders that are affected or come about from your stressful life or stressful behavior. And anxieties affect two main areas. They affect your autonomic response, which is the parasympathetic sympathetic system in the short term. So all the symptoms are due to your neuronal response to danger. But over the long term, as was eloquently stated, they affect your hormonal levels. Now that's a bit more complicated. I'm glad my dear colleague Dr. Mills was before me, because he went through all the complications for me, so I don't have to go over them or pretend that I know what I'm talking about. So he went through all the HLA stuff. Good. But in essence, what he said eventually affects your autoimmune system. So it makes you sick. So you, in fact, make yourself sick, right? And if you look at it, it's true. So, the other thing about it is that anxiety rarely occurs by itself. There's a high level of comorbidity. What does that slide say? And there's no in. Whatever. But basically, there's a high level of comorbidity, mainly with depression, because, yeah, you start to worry you're going to get sad. But also with cardiac problems. And guess what the kicker is? One of the leading causes of anxiety disorder are people who have heart problems. So they always think that they're having an attack, so eventually you make yourself sick. Okay. So therefore, anxiety types can be broken down into two categories, basically. You have the sporadic, which are the acute ones that are mainly neuronal. So these are ones that fight or flight mechanism. Boom, 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 boom. And the symptoms are almost identical. In fact, they are identical. They only vary with minor nuances. And then you have the pervasive. The pervasive anxiety disorders now are the problems one, because they don't just affect the neuronal aspect, they also affect the cortisol levels and the hormonal aspect. So that's why you get more complications with these types. So, in a nutshell, that's most of the anxiety disorders. There are a few there with drugs, a few there without drugs, medical problems, everything causes them. But that's, in general, everything that could go wrong with you. So, let's look at the most common one, or one of the common ones, the panic disorder. Everybody at some point in time has had a panic disorder. Yes? Or you've done very good drugs most of your life. But yeah. But panic disorders are discrete attacks that occur for 10 to 15 minutes. The attacks are short-lived. You have fight or flight response, which is chest palpitations, shortness of breath, panic, sweating, tingly things, other things, GI things, which he went into. Yeah? And cardiac things. Yeah? But it's short-lived. And guess what? You feel like you're going to die. But the difference is, and this is very critical, to make the diagnosis, you have to make sure that the patient does not die. If the patient dies, it wasn't a panic attack. Very important. A lot of people miss this. Yeah? A lot of my colleagues miss this. Yeah? And this is critical. Patients don't die. So after 10 to 15 minutes, the patient recovers. That's a panic attack. The disorder occurs when the patient has developed a pattern of attacks, where they keep getting this over and over again, and now they're spending most of their time for at least a month worried about whether they're going to get another attack, which then causes them to get... It's like you... Yeah. This is why psychiatrists do drugs too. I'm just saying. We really don't. So, it's true though. Epidemiologically, it's a very common illness. It's about 10 to 15% of the population. That says 2 to 5, but yeah, they lie. But it's quite common. It's about 10 to 14% of the population, and it's more so in patients who are in cardiac clinics. Yeah. And all the symptoms are basically symptoms of your autonomic nervous system. So if you know your parasympathetic, sympathetic pathway, which medical school should have taught you, you would be able to pan them out. They're all the same. There's no complication, no difficulty in this, right? The problem is that very few people go to their physicians. You have a panic attack, you just ignore it, because you don't want to go to people to tell them that you have a problem with fear, especially if you're a Jamaican man. That doesn't quite work. So the issue is that most people don't seek treatment, and despite being one of the most common mental disorders that there is, it is very rarely seen in our mental health clinic. So people who see them, general practitioners, and the Obia people. So, like, really, this is Jamaica, we know that's true, not lying. So the issue is that these are the people that see them. And because these are the people that see them, these are the people that really should treat them, not the Obia people, general practitioners. Now, here's the thing. You can change the name of a panic attack or a panic disorder if you know what's causing it. So the phobic disorders are panic disorders that have an identifiable cause. That's like fear of heights, yeah, spiders, doctors, yeah? And most of you in this room have some form of phobic disorders. It's the fear of anything that will not kill you. And remember what I said, heights does not kill you. It's the landing, yeah? And this is also very common. Simple phobias are common. Simple phobias are very, very common. We all have them. If I were to do an analysis now, half of this room would have a simple phobia. Yeah? Fear of guns, bullets. Social phobia is not as common. Social phobia now is a very complicated illness because social phobia causes immense dysfunction. Problem with anxiety disorder is that despite the hilarity of the episodes when you see them happening, they really don't cause much dysfunction in the patient, which is why most people don't seek treatment, and they just let it ride, unless it becomes debilitating. So if you develop fear of spiders and you have to work in an arachnid farm, then you might have a problem. I personally can divulge my own personal phobias. I have a fear of people with phobias. The most irritating people in the world to treat. Yeah? They are. I'm like, we have to do flooding. But I'm afraid of it. That's the whole point. It's a nightmare. Now, So that's the phobic disorder. And it's not matched now. If this panic disorder or phobic disorder now becomes extensive, the flip side of this now is the general anxiety disorder, which is not as common as they want to put it out. But now it's for 6 months. You have 6 months of worrying about everything. Difficulty controlling your worry. Most of the symptoms are present for almost every day. You're worried constantly, and that's now when you move from neuronal to hormonal. Work with me, people. Work with me. Hormonal. And so GAD now is now morely associated with medical comorbidities because you now get the autoimmune problems, the GI problems, long-term, cardiac problems, etc. Hypertension, not quite. Yeah? It's 4% of the population. Most are females. Like really? You didn't know why? And also in the elderly. For some reason, however, in a few years, it's been stated that there's a predicted increase in GAD in North America. I couldn't guess why. I don't know why. I don't know what's causing the increase, but it's still very low. All right, so now this is the coup de grace. And I put this here because it's one of the most difficult disorders to discuss and to treat. In fact, in most cases, this disorder should be by itself. And in fact, DSM-5 took the correct approach by removing this completely from the anxiety disorder category, even though I put it back there, and put it as a disorder by itself. Because when it comes to stress, this is the granddaddy of them all. It even has stress in the name. It's post-traumatic stress disorder. But this is not your regular stress issues, right? This is a disorder that comes about after a person has had significant stressors in their lives. This is life-threatening or threat to integrity, yeah? So it's something that's going to kill you or destroy your life as you know it. And what happens is that the person's normal mechanisms for dealing with stresses now becomes completely deranged. So what they have then is that they get stuck in the process of mourning or getting your brain to process difficult problems. You have a pattern, eh? Go through different emotional states because that's how your brain flushes out the toxic emotions. You get stuck. So the person is deemed to continue. You know, say if you don't know your history to relive it, this is what happens with these people. They are always reliving the same trauma over and over again. And one of the classic symptoms, first one, is re-experiencing trauma. So they have flashbacks, nightmares, they have vivid hallucinations at times, and in fact, some may actually need antipsychotics. They have a hyperarousal state, which can be confused with GAD, because they're always worried, but it's more than worry, is that they're always expecting the worst to happen. And then, lastly, but very poorly understood, is that they have avoidance. I say poorly understood because people just say, oh, if you get hit by a car, you avoid cars. It's not that. You avoid all emotional and physical and psychological cues that are associated with motor vehicles. So these are people who will de-learn how to drive. They tell you that they can't drive anymore. Or they go blind, or they don't talk about things with emotional reactivity. So you can always tell because they're recounted it, and this is a problem with us. We like to find out what went wrong. So we go and we ask them, so tell me about what happened when you didn't get murdered. And they will tell you. They will tell you. But what you notice is that their emotional processing of the event is missing. So they are reporting it, and the details are very clean. But all you are doing is re-traumatizing them. All they are doing is distancing the emotional connections even further. Because when you talk about a traumatic event, you should cry. Not for us, for the ladies. You should bawl. Whatever. No. The reason why this illness is such a devastating illness is because it is completely, the cause is completely identifiable. And in most cases, the cause is man-made. It is not just us making ourselves sick now, it's us making other people sick. The most common traumatic event associated with PTSD, and there are two, 50% of the illnesses associated with being a captured prisoner of war or a rape victim. Guess which one is more common? So, this is the problem. This is a man-made problem. It's a man-made problem. And so that is, in essence, why the disorder is so devastating. Because when you look at the prevalence rate, it can occur in nobody or it can occur in everybody depending on the environment, the social environment that they exist in. Okay? So that's the critical problem with this. See? So it ranges from 3% to 75% of people experiencing trauma. They get completely, the prevalence rate is completely dependent on what your community is doing, what your people do to each other. Okay? All right. Told you rape victims and associated victims. And that says what? Basically, it shows that men are probably more likely to get PTSD from the same trauma than women. I don't know if women are fear of sex anymore, but still. Yeah, men are usually more likely. I hope that was what it says. Anyway, so how do you treat PTSD? Apart from the drugs, and believe me, drugs are necessary. Absolutely. The reason why I spend a little time on PTSD because we have the potential, just like the people who caused the trauma in the first place, to make it worse. And by we, I'm talking about physicians. Getting the patient to recount the traumatic event is going to make it worse. I say this again because I like repeating myself. Getting the patient to recount the traumatic event is making it worse. So when you have a patient coming to you who is a victim of rape or a victim of psychological or physical trauma, and you're saying as a physician, listen, let's tell me, I know it's going to be hard for you, but tell me what happened. It's pointless. And it's also irrelevant. You don't need to know how many men were in the room or how many men came in. And it's pointless. It doesn't make sense. What you have to focus on and what I focus on is what are the symptoms the patient is having? Are you sleeping? And usually that gets them, because most of them aren't. Are you eating? Are you feeling sad? Do you feel like killing yourself? And yes, that's a real question. You ask it. So that's the issue. Because as a physician, most of your therapeutic interventions begin from the first minute you say hello. So if you have a rape victim who's a female, you're a man, it might help to not say hello, but again, a lot of the studies are out on this. But always get the patient to feel safe and ask them, do you feel safe? Do you feel safe? All right. So we have to be very, very quiet because I'm usually very, very loud and I don't need a mic. So do you feel safe? If you have any concerns about whether or not the patient feels, ask them. Because the first part of recovery is establishing emotional, psychological, physical safety. Once the patient feels safe, then you can go on to the other aspects of it, which is actual mourning, going through the mourning process. And you have to walk them through the stages: denial, the anger, the bargaining, the depression, the acceptance. Because after they have reached the level of acceptance, that person will then become functional. Notice I never said cured. Functional. They will never be the person that they were before, so that's why the mourning is there, because that person is dead. And they are going to mourn the death of that person. It's true. Trauma, you never are the same person. You cannot go back to being the same person. And it's the death of that person. This is something I put there for comic relief. We have never seen much of it. It's very devastating, but Hollywood tends to glamorize it. How much minutes do I have left? I put it there because I want to go to the next slide. So we know OCD. Yeah? This is why I want to go. This is where we use great drugs. Yeah? They've been using LSD, marijuana, you name it, we've used it to treat this. And that's why most people come out and say, oh, doc, I have OCD, especially in Colorado. Well, not anymore in Colorado, but certainly in other states, they come out and say, oh, I have OCD. I keep washing my hands. OCD is a very debilitating disorder. People who have OCD don't function. They don't go to the police force and do very well. All right, well, they don't function. because they spend all of their days going over whether or not they turn the light switch on. So that's what OCD looks like. It doesn't look like monk, okay? Or other white people that put it. And these drugs work too. And that's why I put it here, because I like that. It's fun. Okay, thank you. My time was done.
You're awake? So no bias. All right, thank you very much, Doc. That was excellent, excellent presentation. Okay.
Yeah, that's exactly what.
That's it.
You know? Let me say, as healthcare professions, we are driven by our internal desire to help people. Yeah, but here's a problem. There is no handbook on how to deal with that because nobody expects it to happen. There is no pill. There is no way to deal with it. And in fact, you trying to help may actually make it worse. There's only one thing that I recommend that you do, and that is ask the young lady, my dear, is there anything I can do to help you? Let her tell you. Because in terms of referral, you go tell her she wants a referral to the psychiatrist, and she said, if she know mad. It doesn't. If she wants somebody to talk to, let her speak. If she doesn't, that's fine. Ask her if she wants someone, what would she like you to do? And very good information will come out of this. Because if she says, I want you to give me something to kill myself, then you know exactly what to do. Yeah? You can't unfix the problem. None of you can. And especially when it comes to dealing with severe trauma, it's not about the patient, it's about you. Because you are going to be dealing with your own inabilities to make a difference. And that's what you're confronted with. Your helplessness. Your complete and utter helplessness. And when all human beings are confronted with their own helplessness, it makes them uncomfortable. So you're right. Some of you will get the problems. But it's true, you are just helpless. The only thing you can do at that time for that young girl is ask her, dear, what would you like me to do for you? Because that in itself is immensely therapeutic. Is there something you'd like me to do for you? If she said no, say, okay. And you reassure her, if there's ever anything that you need me to do, come back, please. Let her come. Don't even tell them about the Woman Crisis Center, because sometimes that just don't work. But there are avenues there are places for help. And the issue is that once she's ready, if she says she needs some place to go, something to do, then you can work on the specifics. But don't try to fix the problem, because you can't fix it unless you have a time machine and a gun with bullets. You can't fix it. All right? So I hope that helps you, because people get overwhelmed at it. The problem is bigger than you think it is, but it's also not as big as you think it is. In other words, you can't manage the problem, but you can do something. And all you need to do is to empathize with that child at that point in time. Hope that helps.
Okay, so we've had 3 questions, one statement, and we'll take one more question, and I see a gentleman at the back. You have to go shout now, you know. Okay, all 3 doctors. you just graduate, don't it? Just leave, no?
That's great. There are lots of lifestyle changes that work. So you talk about sleep from 10 to, what? 10 to 2. Yeah. Most parties in this country don't start till 12 o'clock. Sorry. And the other thing is that sex relieves stress. And sometimes sex don't happen before 10. So you have to balance it. There are lots of things that you all know to do. But the reality is that you have to be able to fit them into your life. And that's the tricky thing. There's something that's never been mentioned. Well, I've mentioned it many times. But we all have mentioned it. Yeah? Because each of us have it in common. Every single patient that comes in, you tell them, and you can ask them if I'm lying, you know what you need to do to make your life better? You need to diet and exercise. And by diet, I mean eat appropriately, not go upon the injection and starve yourself on crackers.
How do I de-stress?
But
I
diet,
love the game of
eat
chess.
properly. And we give
And
people,
I just
no, we
play
don't
the game.
give them the list of blah, blah things that they should eat. We tell them we don't expect you to go run Usain Bolt 100 meter or go lift, become Mr. Universe. You need 15, 20 minutes, 15, 20 minutes, right? Of exercise a day. Yeah, usually. And it cures GI problems, cardiac problems, mental problems. But none of you do it. So I understand your dilemma, but as he said, you're young, full of energy, yeah? Give it some time. So, no, and for my colleagues over there, it was important because all the pharmaceutical companies came out and were in a TV about this study that showed that diet and exercise was as efficacious as antidepressants in treating depression, blah, blah, blah. They come to me in a panic. Dr. Walker, are you going to mention it? Of course I'm going to mention it. And they say, okay. I said, what are you worried about? You are idiots. You should have it on your marketing board or pill. It's diet and exercise in a pill. We lazy, okay? And we just have to accept that. Don't let the lack of gray hairs fool you, all right? I've been around. We're lazy people. We're lazy. We like drugs. We do. And if the drugs work, take the drugs. If you have the drive to diet and exercise and live healthily, I like you. I don't like you a lot because I get less money out of you, but I like you. And I'm happy for you, yeah? But go on your crusade and tell the people, and the people listen and applaud you, blah. But at the end of the day, nobody ain't go diet and exercise. And they're gonna do drugs. So, yeah, there are lots of things. And Google has a lot of them. Meditation, this and that. I have a patient who suffers from depression. She loves me. Because why? I tell her, listen, sweetheart, you know more things about the spiritual and connecting thing about depression, and I encourage you to do all of them. Just do them. Do them. And she comes and says, what about it? And they say, after you're done, do them, come and tell me which drugs you want. She loved me. It's true.